mentor, a teacher. He was the first doctor to be registered as a palliative care specialist, and we are very proud to be associated with him, to work with him, to be mentored by him. Now, he's an assistant professor in pain and palliative medicine at the Aga Khan University Hospital with great interest in pain and ethical and legal aspects of healthcare. He's a member of the Kenya Society for Pain Management. He also chairs the Hospital Ethics Committee at Aga Khan and leads the East African Steering Committee in palliative care within Aga Khan Health Services. He is a member of the Aga Khan University Hospital in Nairobi, where he heads the palliative care unit, the Institutional Scientific and Research Ethics Committee. He's the chair of the board of Kenya Hospices and Palliative Care. He's a faculty member with ECOPACA and International Cancer Institute and CKBTI projects. He's a peer reviewer with the Journal of Supportive Care in Cancer, BMC Palliative Care, and sub-editor of Palliative Medicine and Hospice Care Open Journal. He has published peer-reviewed articles and written multiple book chapters on palliative care. He is currently leading an international research study on improving pain and symptom management, which is funded by a grant from Rising Tide for Clinical Cancer Research. So this afternoon, we are very happy that he has spared his time to come and talk to us about neuropathic pain. Welcome, Dr. Weru.
Thank you, Esther. Maybe you can stop sharing from your side or from the Secretariat. Asante sana. So I'm just going to start sharing my presentation. Tell me whether you can see it.
We can see that we are seeing, yes, we are seeing the presentation, Dr. Weru.
Okay, so for today we're going to discuss about how do you diagnose and how do we manage neuropathic pain. And our outline will be, let's have 3 questions that we can go through. And after this, we keep the questions aside, see how do we define neuropathic pain. How does it present? How do we assess the pain itself? And how do we treat, how do we manage at the end of the day when our patients come presenting with neuropathic pain? Let's see on the chat box. Esther, you'll guide me on this and see what the answers would be. The following systemic agents, that is drugs which are used, are also used in topical formulation or form from the management of neuropathic pain. So these drugs are used orally through the mouth. Can they also be used, can they also be applied on the skin to manage neuropathic pain? So it can be true or false. So you can write A, T or AF, B, T, BF. I know we are many, but if you can have at least 50 of us reply to this. The following systemic agents are also used in topical formulations or form for the management of neuropathic pain. Esther, you on top of the chat box?
Yes, let me be checking.
Okay.
Please type in your answer to the chat. A lot of responses are false. The ones I can see, there's only one true. Let me count how many they are. So for D, for baclofen, there is a true. 3 of them, and then a majority of the responses are false. Gabapentin topic is available. A is false, then true for baclofen. So the ones that have gotten through, there's D, baclofen, and gabapentin. Everything else, the responses are false. We can carry on.
Okay, thank you. Keep those answers as we go through the discussion. We'll see whether this is true or false for whatever medications. My screen is not moving. I don't know why. Let me stop share and then share again. Okay. After what duration should titration of drugs initiated for neuropathic pain be considered? When do you consider titrating the drugs up or increasing the doses of the medications? Is it after 72 hours of giving the patient the drugs, or is it 5 days to 1 week, or is it 2 to 4 weeks, or is it 4 weeks that you'd consider titrating the doses up? Or even when you hit the maximum, patient gets very severe side effect, when would you consider titrating the drugs?
So majority of the responses is 2 to 4 weeks. There's one response for 4 weeks and 2 responses for 5 days to 1 week.
Okay.
Response for 72 hours, but majority 2 to 4 weeks.
Okay. Thank you. Can we proceed?
Yes. We can proceed. The next answers have come 4 weeks, 2 to 4 weeks.
Okay.
Yeah.
So
and there's one more for 72 hours.
Okay. Okay. The third question is, the following diseases or conditions can cause neuropathic pain, true or false?
So the responses are coming in all true. Then there is diabetes. There is all true, all true, all true, all. Number 3, that is a limb amputation. There's a response all except HIV/AIDS, then all true. So majority are saying all are true.
Okay. So let's now continue. So we all know that pain is an unpleasant sensory and emotional experience, which we can have actual or potential tissue damage. This is a definition that has stood the test of time since 1979. So the emotional bit is what we really need to pay more attention to, because we know that what interventions we do deal with the sensory bit. But it's also what the patient says it is when they say it is there. And this, to me, is very critical for clinicians when you're dealing with pain, because sometimes patients will be in pain, and the way they describe it or the way they say and the way they behave does not really tally with what they are saying is in pain. So what the person say it is when they say it is there. And for neuropathic pain, this is pain from damaged nerves, whether it is in the central nervous system or the peripheral nervous system. Think of any place in your body where there is a nervous supply. And one of the indicators that we are dealing with in neuropathic pain is that it is localized within the supply of a given nerve, what is called the dermatome region or anatomical supply. So this is critical because if you looked at the patient who will come to you and talk about neuropathic pain, it's important for you to ask them, what is the distribution? How does it behave? And where is it? Because you need to map this pain or this distress that the patients talk about when they come to you and are complaining of neuropathic pain. One of the facts about pain is that it's not only physical and specificity that will define pain. It's also defined because we have some psychological, social, and spiritual domains that affect pain. Think of neuropathic pain, or even the other type of pain, the nociceptive pain. And it starts with tissue damage itself, or potential tissue damage. And as we said, on top of that, there'll be some emotional components. And this brings in thoughts. And the thoughts combined with emotions will make the patient now have psychological issues and questions about why they are suffering from this type of pain or this type of experience. Remember, there's a difference between pain and suffering. Pain is in the domain of the clinician. The patient will come to you and tell you, I'm in pain, and then you diagnose pain. But on top of this, it extends beyond the clinician to the patient and the family members or the other people who relate with the pain, with the patient, including where they work, what they do, their families, and their other relations. And this eventually will bring us to saying that the patient has a pain behavior. They are always complaining of pain. Whatever used many years ago to be called Hapa syndrome. Because the description of what the patient is going through, we are not able to pick the nuances and the particularities that the patient will tell us for indication that the patient is suffering from neuropathic pain or the other forms of pain. So it's very critical to get this pain, whether nociceptive or neuropathic, at the point where tissue is beginning to be damaged or has just been damaged before we go to the other modifiers of the experience of pain by the patient. Another fact about neuropathic pain is that it's the most intense type of chronic pain. So nociceptive pain might also be chronic, but it's not as intense as neuropathic. Because neuropathic pain affects the nerves. And remember, all types of pain will have to be transported or transmitted, the nociception, production, transmission, perception, and modulation, the four facets of pain nociception are through the nerves. So when it affects the nerve itself, literally, you expect the pain or the distress by the patient to be more severe than when you're talking about the other types of pain that is nociceptive pain. And patient will variously describe it as cold. I'm feeling cold. My feet feel like I am on ice. I'm feeling numb. It's sharp. Patients will also tell you that it is stinging. I felt like a bee stung me or an insect stung me and then just went away. Some will tell you that they feel like insects moving on their body. And when they try to brush off the insects don't go. Or within a short time, the insects disappear and they are looking at where the insects were. Some will say it is pricking, like someone poking you with something sharp. And then shock like an electric shock. Eventually, some will say it's burning. And some can actually tell you that this part of my body is more colder or more hot than the rest of the body. That I have to go to bed using 3 pairs of socks. That I have to uncover my feet because it's so hot for the feet. So these descriptions now give you the red sign that we're dealing with neuropathic pain. There are some tests which can be done, but the given is the description that the patient tells you about what they are feeling. So all these descriptions are very important when you're talking to the patient and you're assessing their pain, and you're taking the history when patients come complaining to you about neuropathic pain. So notice this fact that can tell you really you're dealing with neuropathic pain. So the question I ask at this point is, we've talked about dermatomes and nerve distribution. That neuropathic pain has got that critical indicator that it behaves according to that nerve route where it supplies. What percentage do you think of pain would be purely nociceptive without a neuropathic component? That's a question we are going to answer as we continue with our discussions. What causes neuropathic pain? We have said that it is caused by any lesion or damage or potential damage to the nervous system, be it peripheral nervous system or central nervous system. It's very critical to understand that there are multiple causes of neuropathic pain that are within our patients that we might miss. For example, in a patient with spinal cord injury, about 67% of the patient will have neuropathic pain experience. This is a number that in some situations is low. Now, given the situations that our patients suffer from, it could be because of trauma, that they got spinal cord injury. It could be because of some compression, because of swellings. It could be because of TB spine. It could be because of fracture of the spine. It could be because of a tumor spread to the spine or to the nerve roots or to an organ nearby compressing on the spinal cord. So studies have shown that 67% and above of patients will have this. Remember also the patient will suffer from the back pain that are inherent within our cultural social context. We've seen many patients with low back pain requiring them to have some postures. You've seen old ladies moving or walking while bent, because our people are bound culturally to carry weights using their backs. And because of this, injuries happen to the back, and the protective system to the spinal cord makes the spine lose its normal curvature with a resultant compression of the cord or the nerves that leave the spinal cord. Then you can have multiple sclerosis. About 28% of patients with multiple sclerosis will have neuropathic pain. However, as the disease becomes more and more severe, this percentage increases. As we also discussed, patients with stroke will suffer from pain. Remember, stroke will affect the biggest nerve that we have, the brain. It could be hemorrhagic or non-hemorrhagic stroke. As long as it's affected that part, patients might complain of some neuropathic feeling. But for you to get this, you must inquire from the patients about what they are feeling, about how they are experiencing their diseases. We've talked about low back nerve root pathologies, and it's higher percentage given our ways of living. Diabetic neuropathies, that one is very, very common, especially for patients with, who have had uncontrolled blood sugars for long. And they might think that it's normal for a patient with diabetes to suffer from this feeling of feeling cold on the feet, or feeling insects, or stinging, or that. We've seen patients who've gotten to a point whereby the neuropathy is so severe, it's also make their limbs weak, that they cannot walk. They are dependent on being mobilized, either on wheelchair or even using walking sticks. This tells you that this has been there for quite some time. We know about postherpetic neuralgia. This one can affect in the dermatome. And this is one of the earliest diagnosis of the fact that it affects the nervous system or the nerves. So there's so many causes, and there's been argument, Hannon and others in one of the international associations for the study of pain, VVs, thought that neuropathic pain should be considered as a disease instead of as a symptom, for example, simply because it can have many other accompanying symptoms, many other accompanying signs. And they based their argument on the fact that when a patient has neuropathic pain, apart from this experience, they also have got other symptoms like withdrawal, like loneliness, emotional distress. They'll also have some bodily changes, because where it is humming or hurting or paining will lose its normal, maybe anatomical curvature and all that. And they say that exposure to drugs, if you combine this with one more causative factor for neuropathic pain, you might not say that this is only pain, because now you have two sources of this distress, and this will be affecting the patient. They also thought that a traumatic nerve injury with compression, this now brings in the patient to change lifestyle. Think of a patient who just had an accident with a fractured back and spinal cord injury, and they are not able to go back to their activities of daily living. They have normal physiological functions like bowel, bladder control, issues of whatever we might call erectile dysfunctions and all that. So the argument was, if this was to come, then you don't just look at the traumatic nerve injury for this patient or the nerve compression of this patient. There's so many other factors. Viral infection, vascular-related neurodegenerative diseases, as we have said. Of course, if you combine this with the nutritional deficiencies, cancer-related disease and treatment-related causes, metabolic ionic disturbances within the body, and the procedures, amputations that we do. All this, the argument by this team was that it might need to be considered as a disease itself because of what the outcome and what the patients go through when they suffer from these myriad causes of what we might see just as one component of causing a patient to be distressed, that is pain, but causing an explosion of the change of the way the patients live, the change of the way they relate, the way they behave, their activities of daily living, and all the other facets that make the total human being, be it physical, be it social, be it psychological, be it spiritual, be it cultural, or socio-cultural norms. All of them are affected when you're suffering from this kind of pain. And remember, we say neuropathic pain is the most severe, one of the most severe chronic pain. Now, how do we now approach to treatment? We've seen the causes, and we've seen how it behaves. We've seen the hallmark. How do we now deal with the treatment? So once you do diagnosis, treat underlying the condition, and then start dealing with the symptom itself. At this juncture, your main aim or goal should be to prevent exacerbation of the pain, or the pain becoming more severe from the juncture at which you've seen the patient. That is one of the aim. But as you look at preventing it from becoming severe, for example, if you see a diabetic with neuropathic pain and their sugars are not very well controlled, you send them to their diabetologist to start and control their sugars. That is one way of preventing the disease becoming severe. On top of that, now start reducing pain with the issue of one, having an outcome of improved physical functioning. If the patient was losing their mobility, you bring them back to their norm of being mobile or mobilization. Now, reduce the pain also with the aim of improving the overall quality of life. Now, quality of life have got what we call objective factors, but also their subjective factors to the patient. One of the most common objective factor for quality of life is freedom from pain. So you reduce the pain, you improve the overall quality of life, or you get the patient to their normal quality of life. At the end of the day, also reducing psychological distress is very, very critical. So treat the disease or the causative factor. If you're dealing with a patient with metabolic disturbances, be they ionic or other factors, treat it. If you're dealing with a patient, for example, we've seen patients with HIV who have not been known to be HIV positive, coming with neuropathy, because HIV itself is a virus, but also the treatment themselves can cause neuropathy to the patient. Treat the underlying condition. But at the same time, it's very critical for you when you're dealing with neuropathic pain, when you're dealing with this patient, to start and prevent escalation of what is causing this pain. Because at the end of the day, if you looked at how neuropathic pain happens with the injuries to the nerve and with the effect of the neurotransmitters between two nerves, all at the synaptic junction, because that is where the current for the neuropathy or the nociception happens, then you'll understand why it is very critical to manage this from the word go. So this is the way we'll approach it. However, you need to assess. And I found this tool to be good for assessment of neuropathic pain because it has got two components. The component for the patient and also the component for you to assess. So it is called the Leeds Assessment of Neuropathic Symptoms and Signs, LANS, LANSS, pain scale. So the first part is detailing what the patient is going through or what they do feel. Pain questionnaire starts like, think about how your pain has felt over the last week and say whether any of the description will match your pain exactly. How are you feeling? And then you give these numbers. So, no, ask about, does your pain feel like strange, unpleasant sensation in your skin? So what, as we have described, pricking, tingling sensation, pins, needles, insects, might describe these sensations that the patient go through. Esther, am I still audible?
Yes, we can hear you well, Dr.
Okay, it's only that power has gone off and I'm using the institutional Wi-Fi. So if you lose me, the power will come back and we'll be back, but we'll continue. So ask about this, and then the patient gives you these words. How do you feel? You're telling me you are feeling bad, you are distressed. Remember, some patients, quite a number, suffering from neuropathic pain, will not call it pain. They tell you it is not actual pain, it's a bad feeling. Tell them to describe that feeling. So if it feels any of these hallmark descriptions that we've talked about, then you scale it at 5. If it does not feel like this, then you scale it at 0. Then does your pain make the skin in the pain area look different from normal? Now, you realize that for those who deal with these patients with long-standing neuropathic pain, especially our people, the dark-skinned, the affected part become more darker, especially on the limbs. In the torso, it become pinker, red, or whealed. And the patient will tell you these descriptions. Now, remember, this is something you are asking and inquiring from the patient. The patient might not really know that this changed skin color, that the leg below the knee, the skin appears darker than above the knees. They don't know that whether that could be an indication that they have some components of pain. So this is very critical for us to ask. Those are 2 points we need to have to ask from the patients. Number 3 is, does your pain make the affected skin abnormally sensitive to touch? Like when your clothes come into contact with your skin, is there a change sensation? Do you wear tight clothes or do you wear your normal clothes? And patient will tell you, no, now I have to wear baggy clothes. We've seen patients with neuropathic pain affecting the lower limbs. They'll come with the folded trouser because they don't want that to be touched. Some will tell you that even a touch by their blanket when they're sleeping is very, very distressing to them, very unpleasant. So when you get this, then you also score. But this now score is 3. Now, there is number 4. These are the bursts of pain, electric shocks, jumping, an insect have bitten you. It's so severe, like someone have just hit you at the elbow until you have had to drop whatever you are holding, and then they just disappear. This is an indication that we also have a neuropathic pain. But if no, then it is 0. If it is yes, 2. Does your pain feel as if the skin temperature in the area has changed abnormally? This we have said, some will say it feels very cold, some say it feels hot. Actually, some family members who accompany patients will tell you, when they touch their legs, when they touch their arms, they feel colder than the other bit. And when they touch, or others will tell you, I thought they were having a fever because it was so hot on their legs. So these are critical. You realize that now this questionnaire is to the patient. Starting from 1, the description that they give you. That, to this questionnaire, or to this tool, carries the most important component. Then the appearance. And then the feeling. And then the behavior of that feeling. And lastly, the changed temperature or the sensation of warmth or coldness on the surface. Those 5 points are very important. And when you get used to assessing this kind of pain, you don't actually need to go through this tool. As you'll see, you ask several questions, and within 2-3 minutes, you know that this patient literally have neuropathic pain. But for record purposes, remember in the medical field, whatever is not recorded was not done. You might need to use this pain scale to record what your findings were. Now, let's go to the testing that you do. Skin sensitivity can be examined by comparing the painful area with a contralateral or adjacent and painful area for the presence of either allodynia or altered pinprick threshold, what is called PPT. So for you, this is now the examination by the clinician. So examine the response to lightly stroking cotton wool. So if there's normal sensation in both areas that you are examining, then that you scale at 0. But if the patient will feel tingling, nausea, when you adjust, usually we use a cotton wool, then that tells you that the sensation is altered, and therefore there is what we call a changed pinprick threshold. Now, altered pinprick threshold, using now the needle itself, you can use gauge 23, and then you just point at the patient, prick them, just place the needle on the surface. If they are either not feeling it, as if there's a needle, or they're feeling so severe pain, then that means that there's alteration. If the pain is not felt in both areas, then it means you're not applying enough pressure, because the normal area should at least have a sensation for this. If it's not being felt, now you can put the silage, usually the 5 cc or the 10 cc, so that you can have more pressure and see whether the patient has got altered pinprick threshold or sensation. So for this altered pinprick threshold, you use either increase or none compared to the normal side. So if they don't feel it, it is altered. If the other side is feeling it. If they feel it and the other side is feeling the normal, then it is still altered. Then in the scoring system, you score, you add the values from the history you took from the patient, the 5 points, and then these 2 points that you examined, and then you score. Add the values from A and B, and you obtain the overall score. Now, get the total score. Now, studies have shown that using this tool now, the maximum will be 24 if you added this, the 5, the 4, the 3, the 2, the 1. With now this 6, because this carry the same weightage, the score max can be 24. And sometimes you'll get patient with 24 telling you this is very severe. If the score is less than 12, then neuropathic pain is unlikely cause of the distress that this patient is feeling. But if the score is more than 12, then the neuropathic pain is likely. And if it increases from 12 onward to 24, now this is the time you need to critically start this patient on management immediately. And how do we manage these patients? One of the key is patient and family education. You'll hear it being called PFE in documents and all that. We take it as it is, but it's so critical that if you don't do this and you go to the other bullets and go to the other drugs that you have, then you won't have been effective and efficient in managing this patient's neuropathic pain. So this is one, as you start taking history, that tool we've seen, you're starting to educate the patient. Once you've done your diagnosis, educate your patient about what the diagnosis is, what the cause is, what the likely options of treatment, and whatever treatment you say, you have to tell them about the side effects and the options. If you're not giving them the option that A, B, C, you might have several options. The patient does not belong to self. Remember, we said that pain now moves from the environment of the patient to the external environment. Therefore, it causes suffering, encompassing the stakeholders in the patient's life. And that's why we need to bring in the family for family education. Imagine a patient who's been walking, they have not had any fall or any trauma, but now they can no longer walk because they have severe neuropathic pain starting from the lumbosacral region all the way to the lower limbs. The family need to understand. Imagine it has extended to even affecting the sensory aspect and the motor aspects of the bladder and the bowels. You need to inform the patient what is happening. Then there's relaxation therapy. Physical and occupational therapy are so critical, but we tend to pay more attention to them when dealing with nociceptive pain and forget that they are also applicable when you're dealing with neuropathic pain. So these are also critical. This patient who is not able to walk, do you require physical therapy? Occupational therapy comes in because now you need to rehabilitate back the patient to their norm. Remember, when they have lost their normal activities of daily living, the things they are used to, is that aspect of rehabilitation back. There's a component called cognitive behavioral therapy that you can use meditation, you can use guided imagery. Some people use music therapy. In the Western world, and now it is catching up also here, there's something called pet therapy, so that patients with pets can have their pets as part and parcel of their non-pharmacologic management. Acupuncture, we've heard about it. Then transcutaneous nerve stimulation. Those are done to assist in pain management. I don't know what you use in your institution, but if you are to stop discussing about management, we would stop at this point, because we tend to rush to the drugs and forget that these are critical components. One, because the patient become an active participant in their own management, in managing their own pain. Two, the family also takes and have a role to play. Three, these avoid the side effects that we know the meds that we use for pain causes. Four, these, once learned by the patient, would become self-management, self-directed modalities of neuropathic pain management. For example, you're seeing a diabetic and they have had these, and you take them through all these. When this disappears and is coming back in 5 years, they'll know how to start managing themselves before they even come to you. So the importance of non-pharmacologic management is the fact that the patient become an active player. The family become part and parcel of the managers in the pain. And then it can always be detailed by the patient to do it some other time if the patient was, God forbid, if the pain was, God forbid, to reappear. Now, how do we approach this? It's tricky when you're dealing with neuropathic pain because of the way it behaves. One, unlike nociceptive pain, the initiation of action by the meds that you use for them to get to maximum serum levels of the drugs, and then for them to have maximum effect, takes a long time. So once you initiate the one first-line medicine, then you begin dose titration after 2 to 4 weeks. start your first-line medicine, the best time is in 2 to 4 weeks. After you started, then titrate your meds. If there's adequate pain control, then follow up regularly and deal with the underlying condition. Continue with the prescription renewals if there are no severe side effects. Now, if there's no adequate pain control, initiate alternative medicine or taper dosing of medicine being discontinued for 7 days or more. Follow up 2 to 4 weeks after each titration. Now, this becomes critical because literature is averse with information, but most of the literature will agree that 2 to 4 weeks is the average that you can use to say that this drug is not working or this drug is working, and then you can titrate it up or introduce a new one. Is adequate pain control achieved? If yes, we continue follow-up. If no, now you can introduce new drugs. If a combination is not sufficiently effective, you need to refer or discuss with a neurologist. Remember, you're dealing with neuropathic pain, or send this patient to the pain clinic. You have pain specialists, you can always send this patient. So of essence is the fact that it takes time for one, the drugs to start kicking in its effect. Two, for it to get to what we call Cmax, that is maximum concentration. Three, for the symptoms, for the pricking, tingling, numbness to start getting off the patient. So basically, this is very opposite of what how nociceptive pain behaves. And whatever drug you start, there are classifications of medications, and these classifications can be combined. So the drugs, let's just classify them before you look at the medications. So they are antidepressants. You have the tricyclic antidepressants. I know we have these medications, especially amitriptyline is so common, and nortriptyline is also common. Imipramine on and off, desipramine also on and off. SNRIs, duloxetine, fluoxetine, venlafaxine are also available, but you can also use anticonvulsants. Things like Tegretol, carbamazepine, I know you have them, gabapentin, pregabalin, lamotrigine. Phenytoin can also be used. Think of any anticonvulsants. Now, if you were to go back now, if you look at this point here, try a combination of first-line medicines. Therefore, it means if you're using a TCA, then you can combine it with an anticonvulsant. You cannot combine first-line for 2 drugs within the same classes. So have foot opioids, because opioids also have got some effect on neuropathic pain, especially tramadol, because of its N-methyl D-aspartate effect. But also we realize that oxycodone also have some effect on neuropathic pain, and also morphine. That is related because it's not the first line for management of any of the neuropathic pain. However, you might realize that once you initiate a patient on some of these medications, they might have some improvement on their neuropathic pain. A word of caution is that if a patient came to you with very severe nociceptive pain and also they have neuropathic pain, you might therefore need to start the management of the neuropathic aspect at a lower dose compared to when you are using only the adjuvant. These drugs are called adjuvant for treatment. Let me repeat. If you have a patient with combined two types of pain, nociceptive and neuropathic, and you're starting them on the opioids, and you also want to give a molecule for the neuropathic element of their pain, then we start on a lower dose of the molecule if you're using the opioid, compared to if this patient had purely neuropathic pain and you're using only the adjuvant molecule alone without the opioids, or without the nonsteroidals and other, whether weak or strong opioids or the other nonsteroidals. Now, what drugs we use? We use carbamazepine, which is Tegretol, but I would want us to look at two columns. The column on maximum dose and the columns on contraindications. Now, if you look at Tegretol, you can go all the way. You start at 100 milligrams twice per day. That's what we do. And then maximum is 1200 milligrams per day. What we have realized is that this tapering up, we get limited by how far we want to go. But you see, we can all go all the way to 12 milligrams per day. Now, look at the contraindication. If a patient has got any sensitivity to any of tricyclic antidepressants, have bone marrow suppression, impaired liver or renal function, most of the patients we deal with might be having some issues with impaired liver or renal function, and you might not go all the way to 1200 milligrams. Esther, are we still on?
Yes, we can hear you clearly.
Okay. Then we can go to duloxetine, which is common. We can start at 60 milligrams once per day. Interestingly, for neuropathic pain, the maximum you can give for this drug is 60 milligrams. So there's no titration for this. Gabapentin, you can go all the way to 1800 milligrams per day, divided 3 times. So the maximum you give for gabapentin is 600 milligrams divided in times 3, which is 1800 milligrams. We start as low as 300 milligrams at night, and then you can go up to 300 milligrams twice a day, or 300 milligrams 3 times a day, depending on how the patient is. But titration goes like that. Then be careful for the elderly and also those patients with renal dysfunction. The patch, lidocaine patch, is usually 5% of lidocaine. You can use up to 3 of them for 12 hours in a period of 24 hours. And if someone has got sensitivity to any of the amide anesthetics, then you might not be able to use. Mexendrine is not a very common drug. It's an antiarrhythmic, and usually most people will avoid it because it's been known to cause some issues with the ventricular heart behavior, and also has been shown also to cause a headache, but it's also used in some places. Now, another common drug is the Pregabaline, the common molecule being the famous Lydica, the common name being Lydica. So you can start at 50 milligrams 3 times a day, and then you go to twice a day. Maximum is 300 milligrams twice daily. I wonder how many of us can go up to this, because we get either limited to go up, or our patients get their pain well controlled. But remember, because of tolerance, they also suffer from tolerance. Sometimes you keep on increasing to that maximum dose. Phenytoin can also be used. Nortriptyline can also be used. And also tramadol. And tramadol can be used at the start dose of 50 milligrams twice a day to 400 milligrams. Esther, let me answer this. Phone is from the hospital, then I join back. Thank you.
Please type in your questions and any concerns in the Q&A box or in the chat box as we wait for Dr. Veru to rejoin us. In the meantime, we can start looking at some of the comments in the chat. Elijah has asked where he can get the slides. Let me confirm with our research department how the slides are usually shared. Lydia asks about medical massage relieving neuropathic pain. I think one of the slides Dr. Veru has covered about non-pharmacologic interventions, and massage was one of them. So massage is part of physiotherapy, it's part of non-pharmacologic pain management.
Sorry for that.
Yes?
We can continue.
On physiotherapy and massage therapy. We have research papers on those interventions, the non-pharmacologic interventions.
Yes. They are used for management of the pain.
Dr. Veru, welcome back, yes.
Thank you. You can continue?
Yes.
Okay, so tramadol is a weak opioid, as we know, and you can titrate it all the way to 400 milligrams. The reason why I put tramadol on this slide is because of its effect on neuropathic pain. And we realize that some patients will need only to be on tramadol to control both their nociceptive or neuropathic aspects of the pain. But be aware of the fact that it's a CNS depressant. There are issues of renal or liver dysfunction, and also the fact that we are seeing more and more patients getting it over the counter. Being an opioid, it should be a prescription-only medicine. And because now the other weak opioids, the codeines, betapine, are controlled because you have to prescribe in a certain way. Now patients have learned to be shopping for tramadol. So be very careful and inquire from the patient whether they have used tramadol before. Now, it is important to note that all these drugs we've mentioned, if they are not working for the patient orally, either because the patient cannot take them or because the patient is getting very severe side effects, or the patient have got very severe emesis, they are vomiting a lot, they are very nauseated, you can always crush these drugs, mix them into a pulp or into a powder, mix them with some water, make a paste and apply it on the region where the patient is saying their pain is. This is mostly applicable for pain that is limited to a small region. So you can crush your Pregabaline, you can crush your phenytoin, your amitriptyline, your lamotrigine, your tramadol into powder, make it into a paste, and then apply it on the affected part. This is critical because for those of you who deal with this patient and you really want to control their pain, you usually get limited by their systems that they're not able to take. And you realize that most of these medications do not have parenteral formulations. They do not have IV or IM formulations. So you can always make them into a local formulation that you can utilize for your patients. Whether about the dose, what you realize is that even if you are to give, for example, using a amitriptyline for the patient at 75 milligram, if you have to crush it, you still crush into powder the 75 milligram, make it into a paste and apply. So there's no limitation as far as that is concerned. But basically what you've been doing is convert what they have been taking orally to the paste and then apply it on the skin where they are experiencing their pain. Remember, that will be external use only. If there is any exposure at the point where the patient is experiencing the pain, then you should not use those paste or the crushed medication. They are for the intact sites where the patient is experiencing their neuropathic pain. My slides are not moving, so I'll stop share and share again. I think it's because of that that break.
That.
You can see it?
Yes, we can.
Okay. Still not moving. Stop share. Okay, so what are the neuropathic pain management novel or emerging treatments? There are drugs which are under clinical trials. We have phase 2, phase 1, many, phase 2, several, and phase 3 trials for the management of this pain. And for bone pain, especially malignant bone pain, we have got underlying neuropathic element. Bisphosphonate, especially midronate, is being investigated. It's gone to phase 3 trial. We're waiting to see whether it will get a go-ahead. This is being done in the US and other countries. Once it's given a go-ahead by FDA, then we'll be using it. However, you also realize that we have been using this biphosphonate for pain with the patient, but not purely for neuropathic pain, but for pain that engage the bones. The other novel analgesics drugs such as ziconotide, which is a corner snail venom peptide, which is under clinical investigation for chronic low back pain and cancer, neuropathic, and post-op pain. These, if they are proved to be effective, then they are going to go also through the clinical trials and marketing stages of the drugs. Memantine is an NMDA receptor antagonist, works just like the 20% component of tramadol, and because of this, is being also tested for neuropathic pain syndromes. It's used for Alzheimer's disease, demented Alzheimer's patients. And also of note is the fact that cannabinoids are also being tested for this kind of pains. Now, what we've had and from reports by patients is that the cannabinoid oil, when they use them, generally their pain usually reduce. They are unable to describe whether it is nociceptive aspect or neuropathic aspect. And since we don't have clear-cut randomized control trials on these medications, they are still being taken as trial meds or supplementation to the normal what we call analgesics that are being used. But you also realize that cannabinoid use for symptoms, think of any symptoms, is on the rise, whether it is in our country or out there, especially in the Western world, where cannabis has been legalized. The medical component and utilization is also increasing with time. Now, the key take-home points are that neuropathic pain is common in clinical practice. So common that you realize patients with chronic pain who come to you, more than 85% of them will have a component of neuropathy to their pain. Individualized approach is very, very important to the management of neuropathic pain. As you have seen, the drugs we use are not what you would call conventional drugs for pain, except the last step of using opioids. These are drugs which were manufactured for other roles, like antidepressants, anticonvulsants. Those are the ones used for neuropathic pain. They are called adjuvants, and they are the best in the management of this type of pain. So when a patient comes to you in pain, classify it in neuropathic. Once you do so, you'll know you are not going to give this patient a brufen, for example, not diclofenac. You're going to give them amitriptyline if you have, Pregabaline if you have, gabapentin if you have. Those are called adjuvant drugs. The pitfall for neuropathic pain management is, unless you realize it is neuropathic and the management is sort of different, you'll keep on pumping the patient with either non-opioid, non-steroidal, anti-inflammatory, weak opioids, strong opioids, without really hitting where it needs to be hit. Drug titration is key. Remember we said you titrate. The best time to titrate is every 2 weeks, but also as you titrate, if you gotten to one, you can always introduce a new one, and that should be very, very subjective. Patient education is a must, and engaging the family is very, very critical. So we have studies that have shown that some patients, unless educated, there has been a component of patient severity of neuropathic pain, especially low back pain with the neuropathic element, having increased severity of their pain if they have had psychological or post-traumatic stress disorder. So the psychological component is key because it modifies the pain for the patient to experience it in a more severe way. So at the end of the day is, are we going to change the way we approach the patient? Are we going to really listen to the patient? Because that listening component is critical. It's the 5 point in the Lance scale that tells you now we're dealing with neuropathic pain. How do you feel? How does it behave? Do you feel anything about when the clothes touch you? Have the skin changed at that point? So this is very, very critical for us to take home. So let's go back to our questions and see how could we have answered them. So the following systemic agents are also used in topical form of the management of neuropathic pain. We have said all these drugs, because they are used also for management of neuropathic pain, they can also be crushed into topical powder, made into a paste and applied. So this is true. After what duration should titration of drug initiated for neuropathic pain be considered? If there are no severe side effects, usually the rule is 2 to 4 weeks, as we have said, because it takes time for the drug to build to the max level in serum, for the symptoms to change. Remember, the symptoms are the indicators that we are either improving or not improving. And eventually, the following diseases condition can cause neuropathic pain. It's all of them. HIV itself, its treatment can cause neuropathic pain. Stroke, as we have seen, phantom limb sensation after amputation, there is sensation. There could be neuropathic pain. Herpes zoster, diabetes, cancer, and all the other diseases that we have seen. So if you see patients with these diseases, even as you talk to them about their symptoms or other symptoms, talk to them about pain. Remember, pain has been described as the fifth vital sign by the Joint Commission of International Hospital Accreditation. So as you talk to the patient, whatever disease, please inquire from them about pain. Thank you. I want to stop there so that in the next few minutes, we can have a discussion, have Q&A. Thank you so much.
Thank you, Dr. Will, for that very enlightening presentation. So I'm going to go through the Q&A. I'll try to group the questions that are similar. So there's a question about relationship between age and neuropathic pain. Is there any? The causes and predisposing factors, you had gone through them.
So age and neuropathic pain. Now,
yes, between the age, yes.
As for any other symptom or disease, we tend to suffer from them as we age, simply because there's a lot of degeneration in our body. As our muscles degenerate, as our organs degenerate, so are our nerves. They also do degenerate. So there's a likelihood that once exposed to a injurious stimuli, the elderly will suffer from the neuropathic pain at a severe level, all more prone than someone who is young, simply because nerves are tissues, just like any other tissue, they degenerate with age. However, also be cognizant of the fact that our elderly, as you age, there are also myriad of diseases that we also suffer from that are likely to be associated with neuropathic pain. Think of low back pain, think of the different arthritis that we suffer from, think of the diabetes that are that affect type 2 diabetes that will affect the elderly, think of the stroke, think of the dementia, think of any neurodegenerative ailment that they might suffer from. Think of also the fact that the activities of daily living are also now less compared to when they were very young. Thank you.
Okay. There was a question on the availability of the presentation. Please check the KNH website. On the tab that is written webinars, you will find the slides and the recording of the session today. Now, there's another question, Dr. Will, on and other multivitamins that are used, the NeuroBion for management of neuropathic pain. Are they effective and how long should they be used?
That's a nice question because everybody does get to be on NeuroBion 40 or NeuroBion plain because they have neuropathic pain. Essentially, we should be given the NeuroBions because a combination of the vitamin B, B1, B6, B12, when we think that there could be some element of deficiencies of these vitamins, and these deficiencies are causing the injury to the nerves. However, you realize that the majority of the injuries causing neuropathic pain are not because of nutritional deficiencies of the vitamins that are important for the functionalities of the nerves. So if you are to give a NeuroBion and you give for about 2 weeks without improvement, you should not continue. One of the issues is about the dosage of the NeuroBion. People go all the way to 3 tablets, and more and more literature is showing that you don't need to really go to 3 tablets of NeuroBion 40 or NeuroBion. 1 per day would suffice for these patients.
Okay. Now, Dr. Peter Ongwae asks that how can we optimize management of neuropathic pain in a primary healthcare setting where there is no access to specialists in pain management?
Okay, thank you, Dr. for that question. Usually, if you look at the nociceptive pain and neuropathic pain, you realize that history listening to the patient, communicating with the patient, inquiring from the patient is the main component of diagnosis. If a patient came to you and told you that they have paresthesia, they have ear sacs moving, they're feeling cold, these are indications that you're dealing with a neuropathy. And since most of these molecules, simple molecules like Tegretol, simple molecules like amitriptyline available even from the lowest level of our healthcare system, then it would be possible to start this patient even on those simple molecules, even before you go to the more newer molecules. However, the way I see it, the way we should improve the management is by influencing our people to understand that this indicates that there is neuropathic pain, especially the primary healthcare providers. You realize that most of the patients who come who have pain will primarily go to the clinical officer, to the medical officer, or will see someone out there in the periphery. Whatever we are calling community health situation is why we need to take this kind of influence and discussions and then tell them, look, we have a psychiatric clinic. I went to one of the institutions, they had amitriptyline. They had anticonvulsants. And they were sending these patients for pain management at the level 4 tier to be seen. And the patients were suffering from very uncontrolled diabetes and all that. And we discussed, look, you have all the molecules you require to start this patient. It's at the point of level 4, as we showed in that figure, that you now need to refer this patient. But Dr. that's a very important point, that we need to now train and talk to these colleagues, the primary health care providers, to know how to diagnose and listen to the patient, pick the fact that it is neuropathic pain, and start its management. Asante.
Okay, so there's a concern about the topical ointments. The question is, how long are you supposed to use them? How long, if you make a paste, how long do you leave it on the skin? And how are these topical preparations stored?
Okay, a very good question, and I think we'll need to do an LCT, control the trial and study on this, because generally what we do is we use it only once if it's a topical application, and then if the patient was to take a bath the following day, then they apply again. So basically for us, we use it once a day, but this is not something that is scientifically tried and has gone through the clinical trials. And we can say that the dice is out there and it is open. Studies need to be done. But basically what we realize is patient report about some control. Away from the paste, is the fact that when the patient, we have had some 3 patients who have applied twice, even if we said once, because they felt that the sensation, both of them had, if I can remember clearly, it was some tingling and burning sensation was coming back, and it's controlled their pain. So it's still open out there, actually.
All right. Now, there are a few questions on the complementary or the pharmacologic pain therapies. There's a question on acupuncture. Is it recommended by clinical guidelines or our Ministry of Health? What's your take on that?
Remember, acupuncture is considered as complementary. Therefore, it does not fall under some of the control that other conventional drugs go through. But we're having more and more clinics coming up doing acupuncture. I know it is a Far East Asian kind of practice for relief of suffering for most of the ailments. But yes, patients do report that they get some relief. It's not part and parcel of what we would say is the standard of care for neuropathic pain, but we've had it being done on and off for patients. For patients who are coming from the Western world and are coming to our institutions, we've had patients on reflexology, PET therapy, acupuncture, and also what they call biofeedback therapy. And they say that it has been assisting and they would wish to continue.
Okay. There's a concern that some of these medications that we use for neuropathic pain, their side effects, for example, elderly patients keep complaining that they're feeling as if they're drunk, they're sleepy all the time, even at low doses. So there's a question here about what would be the best drugs for elderly patients, given that side effect of feeling very lethargic.
Another good question. I don't think we can pick any drug and say this is for the best for the elderly. What we usually say is for the elderly, start low, start at a very low dose. Remember, their metabolism and the breakdown of drugs is also on the lower side. So we know that, for example, out there in the community, amitriptyline is available. And as you know, we start amitriptyline at 50 to 75 milligrams for neuropathic pain. For the elderly, I would usually start at 25 milligrams, that's half a tab, instead of 50 milligrams. I'll also do so for a patient with a liver or renal dysfunction. So it's about contextualizing and looking at that single patient and seeing how well can they accommodate these doses. But rarely do we get to say, give this specific molecule for the elderly. Remember, there are all those factors that you need to consider.
Okay, we're coming to the end. So just one final question for you, Dr. Weru. There's an issue about, okay, there are many questions, especially on the topical medications. There's a question about how to manage a patient with psychosomatic pain. And then finally, there's someone who wants to know how to book an appointment with you.
Okay, so psychosomatic.
Yes.
Okay. That's a good question. And when we talk about psycho, we are talking about psychological pain. And this now requires multidisciplinary approach. This whereby you need to bring in your communication skills, but also engage your counseling psychologist and a psychiatrist, if it were. You realize that most of the patients with this type of pain are patients who might have suffered from very severe nociceptive pain or neuropathic pain, has not been controlled, and therefore it goes to that component. If you look at the figure that we showed, when it comes to the issue of suffering, you start with the tissue damage, you come to the pain sensation, you come to the issues of emotions. When these issues now encompass the emotions and the psychological distress, this is when you get to this point. So to undo that, to uncap that, we'll need a team to be in place. You need to engage your counseling psychologist, your psychiatrist, but also you come in now to get the bit of nociceptive pain or neuropathic pain that might be bringing this in. I think for booking to see me, Esther, you able to take them through that, or to take that person through that? You can give them my number.
No problem. Thank you so much, Sally, for sparing your afternoon to take us through neuropathic pain. There's a lot of appreciation in the chat, in the Q&A box. And if you have not managed to answer your question, it is not because we don't want to, but there's many questions and limited time. So in May, we are going to have a CME on interventional pain management that includes nerve blocks. I've seen some questions on that. We'll be sure to take you through the nerve blocks and alternatives and durations during that presentation. There are also questions about CPD points and how to access the presentations. We are going to work with the research department to ensure that on the pharmacy and poisons board, on your site, you are able to access subscription to our CMEs. Thank you again for your presence this afternoon, for the participation, for the presenters, and for the research department for giving us technical support. Do have a good afternoon, and we'll see you next month from the palliative unit as we present about pain management in children. Thank you.
Thank you.
You are free to leave the webinar.